name is Hayrun Nisa Bolay. I'm working as a professor at Gazi University in the departments of neurology and oncology. In this video, I will overview migraine without aura. Let me start with a case presentation. Leila, a 28-year-old florist, was referred by a family practitioner due to long-lasting headache attacks. Her headaches were bilateral, more pronounced in the forehead and in the temporal areas. She described them as pressuring, and sometimes she felt throbbing nature with movements. It was moderate pain, and attacks were lasting at least a day, and there was a partial analgesic response. During the attacks, she preferred isolating herself in a quiet place, avoiding daily activities, noise, and the crowd. Screen lights of her computer or mobile were bothering. She had nausea, and flower odors were disturbing. She had 6 attacks per month and up to 20 headache-free days in a month. She had been on SSRI for a year. Leila was diagnosed with migraine without aura as she fulfilled the criteria 1.1 in the ICD-10. The duration of attacks, pulsating quality upon movements, moderate pain intensity, avoidance of routine physical activity, as well as nausea and photophobia and phonophobia were all consistent with the diagnosis. So migraine headache attacks are associated with various symptoms. The sensory disturbances occurring in multiple domains are the most prominent. These are disturbances from bright lights, pleasant odors, sounds, and light touch. And nausea, vomiting, and autonomic features are also associated with migraine. But the questioning should focus on the features included in the diagnostic criteria for migraine headache and associated sensory and vegetative symptoms. So Leila did not have tension-type headache. Tension-type headache features are opposite of migraine, unilateral versus bilateral, pulsating versus pressuring, severe versus mild, and no worsening with movements, no nausea or vomiting, no photophobia or phonophobia. The last item is included in the alternative criteria in the ICD-10 appendix, and it is very helpful for differential diagnosis. Migraine headache is the most common brain disorder all over the world, and it is the first cause of disability under the age of 50. Its global prevalence is 14%. Migraine is more prevalent in women, particularly in the childbearing age. It's associated with certain comorbidities, including cardiovascular diseases, hypertension, diabetes, asthma, epilepsy, depression, and anxiety disorders. Comorbidities are important in planning the treatment of migraine headache. Migraine headache is one of the complex disorders. It's a neurovascular inflammatory disorder. Trigeminal system, brainstem, periaqueductal gray, thalamocortical network are all involved, where neuropeptides, particularly caspain gene-related peptide, and inflammation take place. It is not caused by vasodilation of cerebral vessels, and attacks are induced by triggering factors in the genetically susceptible individuals. There is a central multisensorial disruption in migraine and strategic involvement of thalamic reticular nucleus leading to thalamocortical network disruption provides an explanation for enhanced sensory responses and sensory discrimination problems in more than one domain in migraine. Somatosensory temporal discrimination is critical to perceive consecutive sensory stimuli as clearly distinct, and we showed that discriminating somatosensory stimuli was significantly prolonged in episodic migraine attacks compared to the interictal phase. As you can see here, up to 4-fold prolongation in the SDDT thresholds was detected in migraine patients during the attacks. Such a disruption was not detected in tension-type headache attacks. SDDTs were comparable with the healthy controls and below 50 milliseconds, but the prolonged disruption was observed in migraine patients. Also, the short latency afferent inhibition examining sensory-motor integrity was impaired in migraine attacks, which suggested the presence of increased excitability state in the sensory-motor cortex, occurring several hours prior to the headache phase. Imaging studies were also helpful to demonstrate different functional connectivity between interictal and ictal phase. During the ictal phase, there was a widespread connection between the somatosensory cortex and the pons. Consequently, migraine attacks interfere with sensory processing, as evidenced by disrupted sensory discrimination, increased functional connectivity of somatosensory cortex with the brainstem pons, involvement of thalamic reticular nucleus and dysfunction of thalamocortical network, and also reduced inhibition and impaired sensory integration in the sensory-motor cortex, leading to hyperexcitability. These findings elucidate sensory symptoms seen in migraine patients. Returning to the case, Leyla needs a proper treatment plan for episodic migraine. First, we need to establish abortive treatment, which may include non-steroids, triptans, and antiemetics. Interventional bridge therapy can be considered. Also, she needs a preventive treatment. Migraine preventive drugs with proven efficacy have different targets and include beta blockers, anti-epileptics, ACE inhibitors, and ARBs. SSRIs are not effective as seen in Leyla's situation. Among the treatment options, only triptans, ditans, gepants, and anti-CGRP monoclonal antibodies are specific migraine drugs. They were specifically developed for targeting trigeminal vascular system. All the other drugs are non-specific. And management strategies should also include identifying personal triggers, considering comorbidities, and informing patients for medication overuse and chronicity, particularly important for Leyla's case. Providing headache diary will be helpful for that purpose, and she needs to be encouraged to modify lifestyle. The detailed treatment for migraine headache will be presented in another video, and I would like to thank you for your kind attention.